cancer can stick it. So, guys, this is one of my favorite times in any broadcast that we have. We're going to bring on Dr. Joyce O'Shaughnessy, world renowned breast cancer oncologist. What's up, Joyce? How are you?
Hi, April. Hi, everybody.
Hey.
So good to be here with you again this year.
Yeah,
This is such an exciting afternoon. Congratulations for this enormous effort and this big success. And congratulations for all you do, April, you and all the volunteers. Thank you, thank you, thank you for the fundraising you do for the women who need it, for mammograms and for help with their care. And then, of course, for innovative clinical trials. So important, so grateful and appreciative. We and the folks at Baylor, Texas Oncology, and the other places that you help and donate. So thank you so much for what you all do.
Well, thank you, Dr. O. And you've been a real pleasure to have on many of our shows. You join our triple negative breast cancer broadcast every year in March. And then we've more recently started holding a show called The Beat that's weekly. And I think you've been on that a time or two. And it just means the world to us to have access to you. And for those watching right now, Dr. Joyce O'Shaughnessy is actually my breast cancer oncologist, although she let me go a few years ago, which I do miss you, but then I don't miss you.
Right. Don't look back, April. Don't look back.
Just keep driving forward and kind of forget about that happened or whatever. A little speed bump in the road, our time together.
Right.
But
exactly.
Yeah, I mean, because one of the things that people may not realize, I think, Dr. O, the first thing that you told me was with triple negative breast cancer, which is what I had. The you're good to go date was what? Is it 7 years, 8 years? It's different from regular.
8 years. Different than estrogen receptor positive, which is much longer, decades. Yeah, usually.
Yeah, right. And so usually the for anybody else that their number is 5 years, isn't it?
Well, no, triple negative. Triple negative by the time you get to 8 years, really, you really can say cured. And for HER2 positive breast cancer that's also estrogen receptor negative, not fed by estrogen, their cure date is really year 7 because it really is the kind of thing. Those are fast growing. So if it haven't come back by then, it's not coming back. But the estrogen receptor positive breast cancer can be slow or it can be fast.
Gotcha.
And the fast ones usually come back within about 12 years or so, but the slow ones can come back 20 years later. So they get to see me all the time. I can't let them go.
Right.
So, but they do very, very well in general, actually.
That's really cool. That's good to know a lot because you hear a lot of people talk about, their time frames and being let go from their oncologist and different things like that. So it's really, really good to know how that all works because you don't realize, you're right. If it's fast growing, it's going to be one amount of time. If it's slow growing, it's going to be another. Like you said, slow growing, it might not show up till way later. It's a little scary.
Right.
One of the things that I love to do whenever we have you on the show is just to talk about the latest in research and trials that you're involved with down at Baylor Sammons Cancer Center in Dallas, Texas. What's the latest going on there, and how has the pandemic affected your research and trials?
Yeah. We have been a little slower to open up new trials, April, because we wanted to be sure that it was going to be safe for people to be traveling distances from their home and everything. We've been trying to minimize traffic into the cancer center to women who really had to come in for their therapy. We've been putting off follow-ups, et cetera. So I just wanted to make sure that the pandemic was under control here in Dallas before opening up a new trial. And but we really are there. We're really there and about to open up a trial that we've been working on for some time. And it's similar to other trials we've done, but it's the third trial in a series of 3, with the goal being to prime the breast cancer so that it actually will respond to subsequent chemotherapy and immune therapy. Because a lot of the cancers are, they're kind of resistant to immune therapy. They're resistant to chemotherapy that can cure the cancer potentially. And so you have to prime the cancer first to get it to a point where it will actually then be able to the woman will be able to mount an immune response against it. So we're going to be opening up a trial where women get, as a priming agent, a biologic. It's a biologic agent that is approved actually for multiple myeloma, and it really super duper changes the DNA of the cancer. This is a triple negative breast cancer, metastatic triple negative breast cancer. It changes the DNA of the cancer, and then the woman is subsequently, so she gets that first, and then she gets a a chemotherapy agent that really breaks up the DNA, puts further stress on that DNA called cisplatin. And then that's in combination with Keytruda, the immune boosting agent. So we're hopeful, where it's innovative. It's innovative. It's not that many trials around the country going on that are doing that, priming, changing the cancer first, and then treating the woman with cisplatin and with Keytruda. We have another similar trial going on right now that's been open where we treat women with a different priming agent first that inhibits a resistance pathway called the PI3 kinase pathway, and then comes in with a DNA damaging agent after that. And then we bring in the immune therapy after that. So that's been what I've been most interested in, April, in terms of something just innovative to really change the cancer first, and then come in with what you think, hope could even in some patients be curative therapy, because we've had some successes with this along the way, sometimes, by even accident some years ago when women were on other clinical trials, and you're like, wow, that woman got an incredible response. Why was that? You know what I mean? So it's one of those things. That's what research does. You uncover findings, by, surreptitiously, by complete coincidence, basically, and then you follow up on it. So, I've had women basically be able to, be completely free of disease for many years, and others who have gotten very prolonged control of disease. So, it's something I think is an approach that can work for some triple negative breast cancers. Unfortunately, like everything else, it will not work for all of the various subtypes of triple negative breast cancer, but that's our job, is to figure out what subtype it'll work for. So we're still doing that, April. We've been working on those kind of trials here for several years, but this new one, the bortezomib, followed by cisplatin plus Keytruda, really is just opening now. We're ready to go.
Wow, that's so amazing, and it's just the coolest thing to hear you talk about it, because it's kind of like somebody was on some other kind of treatment, and then you did this other thing, and then it was like, whoa. It's like when the guys at Reese's mixed the chocolate and the peanut butter together. They were like, "Holy crap! Look what happened!" I mean, it's a tad bit more complex than that, but I mean, it's the same kind of surprise that where you're just like,
Whoa,
wow, what happened?
How come that happened?
Yeah,
exactly.
Yeah.
No, it's really true. That's exactly what happened, April, and that's been the holy grail, is to recreate that. It really is true.
Yeah, it's amazing to think about, because you're saying all the different things. It's like you take this one thing, you get it ready, and then you take this mix of these two other things, and then you hit it, and that's what's having an impact. And to be able to, I'm just so thankful that there are people out there like yourself and all the research and developers that are out there that are figuring this out, because that. Gosh, man, that sounds like a lot of work and really hard to figure out the exact mix of things to make things happen.
Yeah, and it's we do 10 patients at a time. April, we'll do 10 patients like that.
Mm-hmm.
The bortezomib first, and then just to give this is how research works. And then if it's really, really exciting, we'll stick with that. We'll enroll 10 more patients. But if it is not a home run, then we will add the bortezomib to the cisplatin and the Keytruda. Do you give them sequentially, or do you give them together? So we'll be able to, and you just move as quickly as you can and try different things to try to get the best results that you possibly can. The other thing that's really, the main thing, I should say, not the other, but the main thing that's really exciting right now in triple negative breast cancer is immune therapy. And there are now 2 clinical trials in women with stage 2 or stage 3 breast cancer that is, again, larger in the breast and axillary lymph nodes, but not metastasized, where the women are receiving preoperative chemotherapy with one of the immune boosting agents, the so-called checkpoint inhibitors, and one is the Keytruda and the other one is Tecentriq. And both of these trials have shown that when you add the immune therapy onto the chemotherapy before surgery, and then the women go to surgery, that there's about 20% more patients who have no cancer left in their breast or lymph nodes. And the 20% really pertains to those who's had the more serious disease to start off with, those with lymph nodes involved. And that's what we're most interested in, is those who have lymph nodes involved in the beginning. We know their outcome is not as good. The cure rate's not as high. And so Fortunately, it was the higher risk women that got the bigger benefit from adding the immune-based therapies, the Tecentriq and the Keytruda. And so now the FDA will have a chance to really look at all the data very carefully and hopefully approve these as so it'll become a standard of care. So that's very, very exciting. And then early data, just very early data, a year and a half down the road, suggests that there's fewer recurrences when you add
Wow.
the immune therapy on. Not only is there 20% of women who have no cancer left when they go to surgery in their breast and axillary lymph nodes, but even more importantly, there's fewer recurrences, and it's still early in terms of the follow-up, but
Right.
very, very exciting. So this is huge. This is
Yeah.
huge to get into the curative setting is huge.
That's so awesome. I loved chatting with you about this. One of my favorite things to talk to you about. I mean, there's lots, but is just how cutting edge you guys are with the research and trials and all your knowledge of what's going on out there because that's important. I mean, everybody we're always talking about, let's do this for a cure, and we really are. And I want everybody watching to know that the majority of the funds that we donate out go towards research and trials. That was our original call. That was the first thing that we wanted to do. We've been donating to research and trials, I think, for 6 or 7 years now. We then added mammograms and financial assistance a little later. But we're always going to keep research and trials in the forefront because we all want that more than anything. But to switch gears for a second, when we were talking earlier, we were talking to a breast cancer survivor who mentioned that she hadn't had any children yet. And I mentioned that I hadn't had any children yet either. And that's a known risk factor. So Lynn Bartnett wants to know about the difference in risk factors if you have and have not had children. Could you provide some insight? Like, why does that play a part in it?
hmm it's interesting. It really differs. We used to say right across the board that women who had not had children or had children later um, would have an increased risk of breast cancer. That used to be kind of the blanket statement. And the thinking was because pregnancy fully matures the breast ducts because they have to become, completely mature breast cells in order to produce milk. So once they produce milk, they're so mature, they're less susceptible to insult by carcinogens. Okay. So that was the thinking. And that if you had that occur early in life, 20, 22, 23, very early in life, that, you'd mature those cells and then have your whole rest of your life, to be protected, not 100%, nothing's 100%, but be more protected from carcinogens. Now, that turns out to still be the case. Well, the other thing that they said is that was true up till age 30. But then if you had your first pregnancy after age 30, that slightly increased your risk. Probably the thinking is there that by 30, what happens is that our hormones are just normal hormones. And to some extent, even hormones that are part of contraceptives, for example, hormones, female hormones, whether they be natural hormones, from Mother Nature, our ovaries, or whether they be, contraceptives, the hormones actually can cause some damage to our DNA. Now, Mother Nature takes care of that because when we have a menstrual period every month, when
I
the
was like, oh, lucky people.
hello, I know, yeah, exactly. That's a dream come true. But when women have a menstrual period every month, the breast cells actually they've been getting ready in case the woman gets pregnant. They were getting ready, but then when she does not become pregnant, they basically die back. There's a big dying back process, and just like the leaves falling off the trees every fall, that's Mother Nature's way of cleaning the breast. But the more menstrual cycles women have, there's more opportunity for things not to completely get dyed back every month. And so the older gals get, then there's a little bit more chance of a buildup, of some damage to the DNA. And then if they get pregnant, after 30, well, that's a big hormone surge, to get pregnant. And so that's probably why after 30, it was a little bit. We're talking very small risk now. We're talking very small, but across the population, that could add up in terms of just the impact on the population. But for an individual woman, it's teensy elevated risk. Now, the interesting thing is that now we know there's different epidemiologic risk factors for estrogen receptor positive breast cancer versus triple negative breast cancer. So interestingly, what I just said about having children young and having the breast mature, etc., and then also having more children, more pregnancies where the breast tissue gets to be fully mature, make milk. That actually is a positive for preventing estrogen receptor breast cancer. Guess what? It's the opposite for triple negative. It turns out that early age at first pregnancy and multiple pregnancies increase the risk
Wow.
for triple negative breast cancer. So that's a little bit of a puzzle, quite
That is
frankly.
interesting, isn't it?
Yeah,
Wow.
yeah, yeah. It's the opposite. So, the thing is, the truth is, we don't we don't have a lot of control over that one. You know what I mean?
Yeah.
Women don't. And so, I think it's best probably to put our focus on the things we do
Right.
have control over in terms of preventing. Or I don't like to say preventing, because nothing we do can prevent it. You know what I mean? We can lower the risk is
Right.
what we
Right.
can do. You know what I
Right.
mean? And so those things there are to, we know that exercise. We know exercise lowers the risk for breast cancer. About 2.5, 3 hours of just moderate walking, kind of aerobic at the moderate walking pace, basically reduces the risk for breast cancer. Just either low or no alcohol. Now, low alcohol means less than 1 drink a day, because we know that 2 drinks a day raises the risk for breast cancer. 3 drinks a day raises it more. It's a stair step. It's a stair step thing. So 1 drink a day raises it a teeny bit. So we say less than 1 drink a day. And I think it's probably best. I don't think binge drinking is a good thing, because binge drinking, really gives a high level of alcohol, and alcohol is very toxic. It causes DNA damage, to all of our cells, and including our very vulnerable breast cells, because our breast cells are always under hormonal influence. You know what I mean? So they're always working, they're always changing, they're dividing, all this, and they're always being stimulated. So we don't want a lot of toxins around. And so I always tell my women, just don't drink any more than 2 drinks at a time. You know what I mean? So it's just better, and drink water with it. Keep it diluted. You know what I mean? And so,
Right.
but I think a lot of alcohol is a risk factor, and binge drinking is very likely a risk factor. Smoking in some women can raise the risk. Not everybody, but smoking can also raise the risk. Um, Postmenopausal weight gain. Interestingly, not premenopausal weight gain, but postmenopausal weight gain is a risk factor for developing breast cancer. So, of course, maintaining weight when you hit the menopause, maintaining weight is really good. And of course, in the premenopausal years, it's good to maintain weight too, and to try to be as close to normal weight as possible, because when we go into menopause, the metabolism slows and it's harder to not gain weight. So if we've developed those habits as a premenopausal woman, then it's just easier to carry them over into the postmenopausal years. And then lastly, I think what I'm going to highlight is a couple things. One is contraceptives, hormonal contraceptives. Um, all of them, when used for a prolonged period of time, more than 5 years, more than 10 years, slightly increase the risk of breast cancer. Now, once they've stopped, the risk for breast cancer does fall. So I always counsel women to, use them when you need them, but don't, if there's other alternatives, different times of life, there may be alternatives, use an alternative. Go to a different method of contraception. I always recommend not just staying on the contraceptives, when you have choices, for example. And then lastly is family history. It's really, really important that we all know our family history, both mother's side and dad's side. Some of us are not in tremendous contact with all of our relatives. They live around the country, et cetera, et cetera. You know what? Get on FaceTime, get a family group on FaceTime, spread the word, and have people really, tell each other if there's cancer in the family, because we really want to be proactive and consider genetic testing. And even if the genes are clear, if there's still breast cancer in the family, making sure to get 3D mammograms. And if there's a lot of cancer in the breast, go see a breast surgeon and start getting MRIs, regularly, et cetera. So being proactive, erring on the side of asking the questions, should I be considered in a higher risk for getting breast cancer because of my family history, even though genetically I'm fine, et cetera. So I think just being vigilant about the family history is another way for women to, really take
Yeah.
control and, be on top of it.
I think that's such a great point. You know, whenever I was diagnosed with breast cancer, that was something that you said, "Hey, let's do this genetic testing." And part of that, I think it was called like a genogram or something. It's a like a
Genotyping.
Okay, so
Yes, genotyping. Yes.
I did this. I remember did like a family tree, and
Yes.
it was like went back as far as I could and found any instance of any cancer and what kind of cancer, and we put all their names, filled in all their names, put all the types of cancer that they had, and actually found that I had a lot of cancer on my dad's side of the family. But we didn't really like on the surface. I was like, oh well, the only person who's had cancer was my great grandmother on my mom's side, colon cancer. And then I was like, and my uncle who had prostate cancer. And that was really all I knew. But when we went and did that research, like you said, talk to your family, expand out a little bit and find out the history, found a lot of breast cancer, stomach cancer, prostate cancer, a lot of different cancers on my dad's side. And I was like, wow. And to your point, the reason it's important to know the risk factors is, like you said, that means you might need to be screened more frequently or younger. Like maybe you need to start getting
Right.
screened younger. So that's a really important one.
Right.
And I think the moral of your story is, we started out about the not having kids, and that being a risk factor to some cancers that we're talking about, but it doesn't play as big of a role as maybe we had thought. But that's not something you can really control. You don't want to be like, oh, well, if it's a risk factor, I'm going to go get pregnant. We're not going to
No.
go get pregnant just because we're worried about breast cancer. So there isn't really
No.
anything we can do there. So to focus
Right.
more so on the things you can control, like alcohol intake, making sure you stay at a good weight, a low fat diet, things like that. Exercise. I think you told me one time, was it 30 minutes a day can decrease your
Yeah.
risk by an
Yeah.
extraordinary amount?
Yeah. For now, women who are breast cancer survivors,
Uh-huh.
3 hours a week. So about 30 minutes a day, but you can break it up however you want. But 3 hours a week of moderate walking, whatever you like to do that's at the moderate walking pace, reduces the risk of dying of breast cancer by 50%.
Oh my
So,
gosh.
oh my gosh.
It's
That's
crazy, isn't it? And it's like,
incredible.
and I know we're all guilty of it. It's like, oh, 30 minutes a day, I can do that. And then next thing you know, 4 days have gone by, and you're still sitting in your chair watching TV or doing broadcasts on Facebook, FaceTime,
Yeah,
Facebook,
yeah,
whatever.
it's
So
true.
yeah,
We're
it's
zooming around
yeah,
here.
but
Yeah,
but it's true.
yeah,
It's so very important. I don't want to miss. I've got a couple of questions in here, Dr. O, and then we're gonna
sure.
have to wrap it up here in a minute. We've got Kat coming up next. She's a breast cancer survivor. She's going to be sharing her story. She's also a drummer, which is really cool. But this comes
How
in
cool.
from Mandy. She asks, at what age was the youngest breast cancer patient that you have seen?
19
Wow.
years old, and she did great. God bless her. She was tough, amazing, and I call them my babies. I call my babies. But I've seen other very young women, in their early 20s. I have several at around age 27 or so. But yeah, 19. You know what? Actually, you know what? So the 19. I've actually seen a 17-year-old. Actually, God bless her. I was a second opinion for her, so that's why she didn't come to my mind immediately. But that's extraordinarily rare. I've been doing this for many decades now, and that's extraordinarily rare. Thank God.
Yeah.
The average age of getting breast cancer is in the early 60s. Thankfully, breast cancer is quite uncommon under age 40. Only if you take all the breast cancer that happens every year, which is unfortunately about 200,000 plus in our country alone, only 5% of that is under age 40. But we hear about it because it's such a dramatic occurrence in such a young person. People just don't expect it. When people are like, really, so busy in life, and many things that they're doing at that time. So fortunately, it's rare, but under age 30, it's exceedingly rare.
Yeah, I can't even imagine seeing somebody who's 17 years old,
Oh, oh my gosh. Oh, it was awful.
I can't even imagine that. And then 19, I remember when I was diagnosed at 41, they were like, oh, well, you're young. I was like,
Yeah.
but Tim, when you put that point about, the percentage and everything, and you did say that the majority of women who are diagnosed with breast cancer are actually over 60, which again plays to your point of, making sure that as you get older that you continue to exercise and do your part to reduce your risk. And man, I could talk to you forever, Dr. O, and I wish we could keep going on. I have a couple of more questions, but we're not going to be able to get to them today. So I hope that you will come back and be on our show again sometime soon. And yeah, we have the beat every week, and hopefully you can join for that. And then
I will, April.
We'll see you back again, definitely for Triple Negative Breast Cancer broadcast. I can't thank you enough, Dr. O. It's always a pleasure.
Enjoy, everybody. Enjoy the shows. Bye.
Man,
Bye, April.
Thank you so much, Dr. O.